Okay, welcome to Blast Off. This is a presentation that I did to start off our first cohort for uh, people who have either pre-diabetes or diabetes and want to lose weight. And this time I thought I would record it ahead of time and have people watch it ahead of time so they'd understand better what it's about. Because we can't accommodate all the people that might be interested. So I want you to have the opportunity to know what it's about and decide for yourself if you're interested so that hopefully, um, and then we're only going to take the first 20 people who want to do it. So this, I started this program in August of August 31st, I did this presentation and we started in September with our first group. And the reason I called it Blast Off was I thought, well, I'm expecting this to be a blast as far as fun and we're taking weight off. So let's just call it Blast Off. With your permission, we're going to record our meetings, but we're not sophisticated enough to record the group. We just record the person who's speaking and the slides. And that way, if you miss a session, you can watch it later. But don't worry, you won't appear on camera, but your voice will be recorded and we can't help that. So this program is a combination of two programs that were designed by the Center for Disease Control. And so it probably won't come as a surprise that the dietary and exercise advice hasn't really kept pace with the research. Now, the UK, on the other hand, has some programs that are really exciting. But I didn't discover those until we'd already started, but we've already incorporated what we learned from that as well. So, but when I first learned about these programs was in 2017, or no, it might have been 2015, I think actually. And they were designed long before that. So basically, I had to try to bring these programs up to date. T2 Prevent was targeting people who were pre-diabetic and had a weight loss goal of 5 to 7% in 1 year through exercise and dietary changes. The Look Ahead program was people who were already type 2 diabetic but wanted to lose weight. And the goal was weight loss of 10% in 1 year through exercise and dietary changes. And it also incorporated liquid meal replacement. You don't have to lift that heavy weight that you see there in the picture to do weight resistance. It can be resistance bands. It can even be your own weight you're lifting. But you do need to have some type of weight resistance in your life because that's the best way to build muscle. We also found through further research that the critical amount of exercise to maintain weight loss is 200 minutes per week on average. And 60 minutes of weight resistance also was necessary. So the T2 Prevent goal was 150 minutes, Look Ahead was 175, so they just didn't shoot quite high enough. And neither of them emphasized the importance of weight resistance. It's fine not to have a scale if some people have bad relationships with scales and have had issues with them in the past. So if you have that issue, you don't have to weigh at home. But you do have to weigh in weekly at group meetings and at your individual meetings. So that is a requirement for participating in this program. However, if you're up to it, they now have scales that are pretty fancy. They, through impedance, can tell you how much your fat percentage, your muscle percentage, your bone mass, even calculates your basic metabolic rate. And I found it really interesting. I found the scale really helpful. And some of the people in our cohort, at least one person bought the scale and she's enjoyed using it too. I will tell you that I talk more at the end about how I lost weight this past year and a half, and it was a whole combination of things, but um, I do know that I have lost a lot of muscle and then I will have to work to get some of that back or it's not going to be good in the future. Um, the more muscle you have, the more calories you can eat and the more glycogen you can store in your muscles and the more insulin sensitivity. Insulin sensitivity is improved by storing more glycogen in muscles. So that is a problem that I do bring up with people who go on low carb diets that they won't improve their insulin sensitivity. But that's for some people that still is the way to go. Um, but if you want to build endurance, you need a recovery drink after exercise to start storing more glucose in your muscles and to provide protein for muscle rebuilding. You want to start thinking of yourself as an athlete. I did Noom a long time ago, and it had these strange dietary requirements or things that it rewarded you for that just didn't make sense until I finally figured it out. That what they were promoting liquids and or volumetrics was the type of dieting they were promoting, and I found out that it's because it's especially good for those with food addiction. Food addicts eat more to feel full, not necessarily for taste. And so if you struggle with this, a liquid diet for short term can help you shrink your stomach and also feel more satisfied from food. So, and that's part of the thinking behind using some meal replacements as well as liquids. And in the UK, they have a program called Soups and Shakes where they replaced all the meals with liquids for 8 weeks. It was only 850 calories a day. People lost on average 10 kilograms, which is 22 pounds, and 46% of the participants were able to put their diabetes into remission, meaning they weren't taking any medicines and they no longer appeared to be diabetic on their lab work. So it's something to consider. It, a possible meal replacement could be Glucerna. It's a meal replacement drink that's specifically designed for diabetics. And Slim Fast is another option, or some people have used Atkins ones. Um, Even Glucerna itself has ones that are geared more towards um, low carb diets, and then people who are not doing low carb. Again, we'll go into this in greater detail in the group. We're going to discuss all the pros and cons of these different diets. We also, you may wonder, well, how do I know what diet's right for me? We're going to talk about that too. So it's interesting when it comes to testing in athletes to see what the best recovery drink was. They tested it in cyclists and they compared all these fancy recovery drinks like muscle milk and is a common one that you can get. And it's not milk, but I think it has whey protein. But the best recovery drink and the cheapest was chocolate milk. Of course, if you're lactose intolerant like me, that's not a possibility. Um, so liquid diets do work. I will warn you that I lost a lot of hair 3 months after the surgery, after a surgery I had, and after I had to be on a liquid diet for 6 weeks. Um, and I'll talk a little bit more about this when I explain all the things that led to my weight loss. But, uh, and I'm still not 100% sure I understand why I lost so much hair, but it has slowed down. So they, this data may already be out of date, but 9 to 10% of the US population is currently type 2 diabetes, including those who don't know it. From 1980 to 2014, the prevalence of type 2 diabetes quadrupled. The peak of new cases was in 2008, and it's declined some. I suspect that maybe that's from the baby boomers because they're the big meal traveling down the snake. So maybe baby boomers were at the peak age of that where most of them become type 2 diabetic, and now since maybe they've passed that, and that's why it's the rate of new diabetics has gone down. Pre-diabetes, a state of increased risk of developing diabetes, affects an estimated 1 in 3 adults. That's 86 million people, and 90% of them don't even know it. That's a lot of people. 1 in 3. Wow. The risk factors for for becoming diabetic are being overweight, 45 years of age or older, have a parent, brother, or sister with type 2 diabetes, physically active less than 3 times a week, have, if they're a female and they've ever had gestational diabetes during pregnancy, or gave birth to a baby who weighed more than 9 pounds. Race and ethnicity are also a risk factor. African Americans, Hispanic, Latino Americans, American Indians, Alaskan Natives, and some Pacific Islanders and Asian Americans are at higher risk. You can also go to this website, doihaveprediabetes.org, to see if you score a 5 and above. Everyone that I'm inviting to this is somebody who's had elevated fasting blood sugar at some point in the last 2 or 3 years. We had plenty of people who meet that criteria that I didn't have to search for people based on just like hypertension or something. But, and especially because anyone who's Medicare has to have had an elevated blood sugar in the 2 years prior, in the last 2 years. Doesn't have to be still elevated, but it has to be over 100 at least once in the last 2 years to qualify for this program and be covered. So pre-diabetes can also qualify if you've had a fasting blood sugar of 100 to 125, or if you did a glucose tolerance test and it was your 2 hour was between 140 to 199. We don't do those very often anymore, but we have done them occasionally. If your A1C is 5.7 to 6.4, I used to always tell people that if your blood sugar was between 111 and 125, you had a 1 in 4 chance of becoming type 2 diabetic in the next year. And I think that's still true. But without intervention, this larger group of people, 15 to 30%, which is encompasses that 1 in 4, would develop diabetes within the next 5 years. And just know that once the blood sugar is over 111, you're getting very close. Now, I just wanted to mention that one of the things what led to me researching these programs was I think it was no, it was 2017. I said earlier I wasn't sure if it was 2015 or 2017. A patient of mine took part in one of these programs, and she came in for an annual wellness exam, and I saw her first out of the corner of my eye and thought she was a 30-year-old woman. This woman is retired, and even when I looked her straight on, she had a new glow in her skin. She'd lost 20 pounds, and she did the program. She actually did this program and didn't tell them that she had actually had one blood test where her blood sugar was high enough to be diabetic. I think her blood sugar was still under 126, but she did have an A1C of 6.7. But they didn't, this program at that time was being done through the Holt Center. So she did it, and I could see a huge change. She just looked great. She felt great. And I was impressed. So that was what led to me looking into this program. And so she did that in 2017, and she did put her diabetes back into remission, and she wasn't diabetic again until this past year. Her blood sugar had creeped up again. She hadn't been exercising, and it was almost identical. Her blood sugar was right around the 120s, 130s, and her A1C was 6.7. And so she is one of the participants in our cohort that's already doing this. And she's already lost 10 pounds and she's back in remission again. She's going to keep working at it because she wants to make sure that she keeps it in remission. And so, but it's worked again. So that's awesome. So As I said before, this was how the program was set up, but it only had 150 minutes exercise. It was successful in delaying the onset of diabetes by about 4 years. And that was in 2017. She just did it again. She delayed it 6 years. And it reduced the overall diabetes incidence by 34% over 10 years. But as I said, we can do better. The Look Ahead program was for people who were type 2 diabetic. They had to be willing to exercise. They only worked up to 175 minutes. They had to attend 95% of meetings. They had to use meal replacement shakes of Glucerna or Slim Fast. We're making that optional. They had to track diet, exercise, and weight. The dietary advice from that program was so outdated, they were still using the food pyramid. So we definitely knew we could do better than that. So this program is group meetings they're also called shared medical visits or group visits or shared medical appointments. So that's the what we're using to do this. And it's not just a 6-month program or a year, but it's actually a 5-year program. We meet pretty much almost weekly for the first 6 months, and then every other week for the last 6 months. And then you've completed your first year. The 2nd through 5th year, they recommend monthly individual visits and quarterly group visits. Although, honestly, I think we might swap that and stick with the quarterly individual visits and do monthly group visits because I think everyone enjoys the group visits so much. But so we'll see. To participate, the requirements say you have to have a desire to improve your health, a willingness to find your path around obstacles, need to be on time to the meetings, silence your cell phone, be respectful of other people, and most importantly, be respectful of everyone's privacy. Everything said in that room has to stay in that room. Can't go home and discuss the group visit with your husband or your wife or anyone else. It has to stay private. Like I said, we have better science now. You don't have to exercise to lose weight, but you do have to exercise to maintain weight loss. And we now know that you need 200 minutes per week to maintain, and it needs to include 60 minutes of weight resistant exercise. You can even do weight resistance 3 times a week. It'll speed up your weight loss. And we have ways to do it quickly to get you in and out of the gym if you want to go to the gym. But like I said, we have people in this program who can't do weights right now, and it's still working for them. They found ways to work around that. So don't let that stop you from doing it. The old programs also only offered one diet, and it shouldn't be a big surprise there's not one diet for everyone. The right diet depends on genetics, activity, age, psychological issues, and financial issues. So we're going to talk a little bit about genetics now. DNA is in every cell of our body, and it's all coiled up. If you were to take a single strand of DNA, it's about 5 feet long. But if you could uncoil it and stretch it out, it would actually be 3 kilometers or 1.86 miles long, one DNA strand. And we've all been taught that it was discovered by Watson and Crick. But the truth is, Rosalind Franklin captured its structure and photographed it, and her colleague gave the image to Watson and Crick. And they got the Nobel Prize, not Rosalind. A woman was robbed. So the language of DNA uses only 4 letters. These 4 letters, or these nucleotides, adenosine, taurine, guanine, and cysteine, A, T, G, and C, are just linked together, and that's what DNA is made of. And an A always pairs with a T, and a G always pairs with a C. Then long strands of DNA are for making genes, and genes are just a region of DNA that encodes function. They're the basic units of inheritance. We have about 20,000 genes on our 46 chromosomes. We also have sections in our strands that turn off transcription or turn it on, or determine if a whole gene will be used or just a part. There's also other things that play a role in how our DNA is used. For example, methylation. Methylation is adding methyl groups, which is carbon and 4 hydrogen to DNA and covers it and keeps it from being transcribed or replicated. Why would we want to do that? Well, a very good reason to do that is because of viruses. Viruses are so small that they can't even duplicate themselves. They insert themselves into the host DNA in order to replicate. Some of viruses themselves are little pieces of either DNA or RNA, and the difference between them is that DNA has the 4 base pairs we just discussed. And RNA uses uracil instead of thymine, so substitute a U for a T. DNA is usually double-stranded. RNA is usually single-stranded. DNA is more stable because of being double-stranded, that it kind of protects it. In us, DNA is responsible for storing and transferring genetic information, while RNA directly codes for amino acids and acts as a messenger between DNA and the ribosomes that make proteins. So viruses that are made of the DNA type viruses actually insert themselves into our DNA and then use our machinery to replicate. A great example of this are herpes viruses. So the varicella virus is in the herpes family. That's the virus that causes chickenpox. And after you've had chickenpox, it is still embedded in your DNA in your nerves. But we covered that with methyl groups so that we don't keep transcribing it. If we did, we'd keep having chickenpox. But as we get older, or if we're stressed, or we have other illnesses, then our methylation goes down, and then the virus gets replicated, and you break out in shingles. And shingles is no fun, let me tell you. So variants are just what that says. Variants are varieties of our genes. Most of our genes come in multiple variants. There's often a wild type variant that is the more common variant and considered maybe more normal, but not always. And there could be a few variants, or there could be up to 500 different ones. And these variants are also called SNPs. And SNPs stands for single nucleotide polymorphisms. And it's basically where one nucleotide has been substituted for another one. And so, for example, 2 variants of the MTHFR gene, which you can imagine what we call it, frequently discussed are A1298C and C677T. And what that means is that the A at position 1298 has a C instead, it's been substituted with a C, or the C at 677 has been substituted with a T. That's the 2 most common MTHFR variants that we talk about. There are 3 common variants of the ApoE type, 2, a 3, and a 4. There actually is a 1, but it's super rare. And variants are either inherited. These that we're talking about here, the MTHFR and the ApoEs, those are all inherited. So they're passed from parent to child, and they're going to be present in every cell of the body. Then there's non-inherited variants that can occur spontaneously from damage to a cell, like from radiation, ultraviolet radiation, or error in DNA replication. Those only occur in the cells where that went wrong, and they're not passed on to the next generation, but can lead to cancer. So let's talk a little bit about the ApoE gene. How many of you have heard of it? It's based on substitution at 2 SNPs. The SNPs are RS7412 and RS429358. If you've done 23andMe, you can actually search for those in the text file if you download your raw data and figure out your ApoE type. Now, it's not the hardest part is figuring out how to download your raw DNA. So if any of you want me to tell you how to do that, just email me, drknight@thenightcenter.com, and I'll send you the information on how to download. And then you just can do a search in a text file for those numbers and find it out. But you may need help, but if you need help, I'll help you. For those, though, who you haven't done 23andMe, or if you did Ancestry doesn't have the right, it only has one of these in Ancestry. They didn't do both, so you can't calculate your ApoE type, fortunately. So when you look at those two and see what if you have a C or a T, that both of these are a C or a T. If you have a C in 7412 and a C in 429358, then that's a 4, epsilon 4. If you have a C in 7412 but a T, then it's epsilon 3. As I said, I've never seen an epsilon 1. It's extremely rare. Epsilon 2 is if you have a T in both. Now you get one from each parent. So in the next slide, you'll see for example, I'm a 3-3 because I got a T from both parents for this one and a C from both parents for this one. In other words, they both gave me epsilon 3. Now this, since you have pretty much, we're not worried about one, we got 2, 3, or 4, then that means there's 6 possible combinations because you get one from each parent. So you could be a 2-2, a 2-3, a 3-3, a 2-4, 3-4, or 4-4. Those are the 6 combinations. The most common type in North Americans, any race, is a 3-3. Epsilon 4 is considered the more original gene, the one that's been around the longest, and I don't know if it's exactly the same in apes or very similar in apes. I'm not going to go through creation evolution here. I believe in both somehow. ApoE, by changing a base at 2 places in the long string of proteins, changes its structure and changes how it functions. By the way, apes don't have heart disease, but they are vegetarians and they eat their own poop. Extremely high fiber diets. This is true. And so even though ApoE4 usually is the highest risk of heart disease, and most apes are ApoE4, they don't have it. Be interesting to find out if apes can get Alzheimer's, because that's another issue. So the 2 version of ApoE doesn't metabolize carbs well. The 4 version doesn't metabolize animal saturated fat well. So the 4 version has the highest risk of coronary artery disease and Alzheimer's. The 2 is considered protective for Alzheimer's. The 3s, if they have Alzheimer's, is usually from toxic exposures like Lyme disease and mold. And some can happen to a 2-3 apparently, but it's just much lower risk. It's never, there's no nevers. There's still people who are 2-2 who could develop Alzheimer's. Here's the distribution by race. One thing that's really stupid. One thing that's really annoying is when your daughter calls and you're making a recording. But I had to say no. Oh, now I'm going to worry about why she's calling. If she calls again, I'm going to answer. Sorry. Okay, so African Americans, 43% are 3-3, whereas for American Indians, it's in the 70%. Caucasians, it's more like 63%. Mexican Americans, 74%. Why they split Caucasians into men and women and American Indians into men and women, but not African Americans and Mexican Americans, I don't know. I have no clue. I think, though, that since man originated in Africa, it makes sense why there would be more 4s in the African Americans, because they're more original. So this is showing how ApoE and LDL and coronary heart disease correlate. So the 2-2s have the lowest LDLs, and it goes up to 2-3, 3-3, 2-4, 3-4, 4-4. Coronary heart disease, now the one thing, the caveat is the 2-2s do have more trouble with triglycerides, so you see that can cause some more risk of heart disease, so it's not totally flat at the bottom. Or I mean, it should say flat, it's not a totally sloping line. But so the 2-2s and the 2-3s are about equal in risk. It still goes up to the 2-4. Actually, the 2-4s are between the 2-3s and the 3-3s. The 3-3s are more risk than the 2-4s. I didn't realize that. And then the 3-4s and then the 4-4s. So that's for coronary disease and LDL. So this is a table showing how you're supposed to eat for your ApoE type, but it's a very old table. It's from 2002, so it still is very high on carbs. And I think that's probably because they just couldn't let go of the food pyramid back then. Um, the proof is in the pudding, and I have patients who are 2-2s who do go on keto and are able to make huge changes in their labs from that doing that. The 2-3s probably need to be moderately low carb, like maybe 50 to 100 grams carbs. 2-4s also need to be maybe lean toward keto, but also vegetarian, which that is not easy. When I say lean toward keto, I'm not saying keto is actually 20 grams carbs a day. The only people who need to do that are 2-2s, and maybe not even all the 2-2s need to do that. If you're E3, if you're 3-4 or 4-4, you need to be vegetarian, maybe vegan even. But I know of diabetics that are 4-4 that can't do many carbs and they're very skinny because what can they eat? And they're still diabetic because if they did eat carbs, their sugar would skyrocket. Unfortunately, low carb diets don't improve insulin sensitivity. Plant-based diets are also healthier for preventing cancer. So we're going to talk about all this in ad nauseum. ApoE is just one gene. Meat fads, another gene. The fads gene, fads fatty acid desaturase 1 is associated with cholesterol biosynthesis and cell cycle control genes. Now, it's also hunter-gatherer versus farmer. So the C allele needs animal fat and is supposedly more prevalent in Asians and Native Americans. And A allele can convert plant oil to get EPA and DHEA and supposedly more in Europeans and Africans. My husband, who's I think pretty much mostly German, is an ApoE3-4. So he's supposed to be vegetarian, but he's a CC for this one, so he needs animal fat for that reason. So sometimes your genes don't agree. Sometimes you have one gene that says you don't need fat, one that says you do. So but I still am encouraging people to consider at least doing the ApoE type. And you can do that for $125. Insurance doesn't cover it. If you want to know your ApoE, FADS 1, and about 10 more SNPs that are related to dietary issues, you can do that for $375. And that kit is never shared. It's through our office. Or if you want to do that kit and have the full analysis, where I also come up with a custom supplement plan, that's $800 because it takes me quite a bit of time. Our program will be modeled after Prevent 2, T2, with bonus material and even a few extra sessions for diabetics. I'm thinking now, though, I'm going to maybe still combine them all and there won't be extra sessions, but we're going to discuss how to eat for your ApoE type, exercising based on the latest scientific research, adjustments in the curriculum for people with diabetes. In fact, most of the people in this group are diabetic, so but the curriculum worked well for either, and so at least the T2 curriculum was done in, I think, 2010. I've seen people reverse their diabetes with GLP-1 medications and exercise if started soon after diagnosis, but I believe it would work if someone added enough muscle mass, and it can also work without meds using meal replacement. We'll have lots of examples how to do that. We even talk about intermittent fasting. If someone's doing everything right and can't lose weight, well, it's often due to obstacles like undiagnosed thyroid issues, inadequate sleep, food addiction, eating disorders, medications that are sabotaging you, or mold exposure. Mold exposure is huge. Mold exposure also causes Alzheimer's. Just FYI. Worried you can't weightlift. Well, Miriam Nelson was a PhD at Tufts University, and she developed a program to get people weightlifting. And her first cohort was nursing home residents. If nursing home residents can do it, almost everyone else can do it. Now, like I said, there are people in our group now who can't do dumbbells because they have pretty significant arthritis, but they have found ways to exercise. This is So interesting. This is a person who did Miriam Nelson's. This is a cross section of a thigh. The first one, the top thigh, is a moderately active 25-year-old. The middle one is the thigh of a sedentary 58-year-old woman. You can see there's a lot less muscle, a lot more fat. The bone's thinner. You can see the bone marrow's a little bigger. Thigh is very similar, again, to A. But it belongs to a woman who completed Miriam Nelson's training program, Strong Women Stay Young, and was 63 years old. So even at 63, you could get your thigh to go back to looking a lot like the 25-year-old. Even her bones are a little thicker than this other one who's sedentary. And she's 63 years old. So see, it's amazing. Now, probably everyone knows now there's all these meds that also help weight loss. If you have diabetes, Byeta's been out for a long time. One of the first people I put on Byeta lost like 70 pounds, but she didn't lose it just from Byeta. She lost 10 pounds, and then felt good enough that she started going to the YWCA when they used to have that lazy river, and she started walking the lazy river every day. That's how she lost the 70 pounds. But Byeta was what kicked it off. But because the average weight loss on most of these is, 5 to 10 pounds usually. But where I see the weight loss really take off is the people who then start exercising. Now, Mounjaro is the newest one, and it works through two things, not just GLP-1 agonist, but a GGP agonist, I think is the other one. And some people have lost a lot more weight on Mounjaro. Unfortunately, though, it probably also has the least coverage because it's the newest. And Rybelsus, all these in the first row are injected. Byeta was injected. And Victoza were both daily injections. Bydureon weekly, Ozempic weekly, Trulicity weekly, Mounjaro weekly. Rybelsus is identical to Ozempic, but it's actually an oral medication. And it works better than Ozempic for weight loss, but it's also harder to take. It's more nausea. Then we have these SGLT2 inhibitors that do have some weight loss. They make the kidneys excrete more glucose. And so if you're excreting all that glucose, you're not absorbing it, so you do lose some weight. And metformin in the past was considered to be weight neutral or minimal weight loss. Now, some of these same medicines are available for people who are non-diabetic, but just because the FDA has approved them for that does not mean your insurance will cover them. Very few insurances cover them. So far, we've only found that people who are in unions sometimes have good coverage, like the teachers' unions. But if your union is mainly male auto workers, well, there's a good chance they didn't fight to have coverage for these. But, you never know. I can get a generic version of Zepbound and Wegovy through compounding pharmacy, and they would cost $275 to $300 for Wegovy. So if you're willing to pay that, we could get it for you. Or we could give you Zepbound, but that is still $500 to $1,000. Very expensive, even generic. Another thing to consider is looking at the characteristics of people who have lost weight and kept it off. This is just on average what most of them did. Doesn't mean you have to do these things, but it's just something to think about. Most of them weighed at least weekly, mostly daily. I think you have to at least weigh weekly because otherwise you won't know if you need to get back on something, You don't like miss a workout and gain 5 pounds, no. So but if you're not monitoring your weight, it could creep up on you. They exercised on average an hour a day. They watched less than 10 hours of TV per week. They ate breakfast every day. Most of them were also morning people. Most had tried different diet approaches to find what worked for them. The most popular form of exercise was walking. And I will tell you, I see people every day at the gym that are successful as well. And when I was gone for 5 more years, I came back and they looked the same from the neck down. And I'm impressed by those people. So the plan for this program is we'll meet on Wednesday afternoons. The weigh-in time will be from 3:45 to 4 o'clock, and then our group visit, our shared medical appointment will be from 4 to 5. I got 4 to 4. Sorry about that typo. Basically, we do a welcome and review or answer any questions that people might have had from a previous session, talk about our objectives for the night, then we talk about a topic, and then we plan for success by setting goals, and then summary and closing. This is the schedule of all the different topics. I'm going to include this in the email so you don't have to be able to read this. But don't worry, it doesn't end there. We'll meet monthly for 5 years. We will start new classes every year. If our group dwindles, we can always add groups together. An online option. I was thinking that if you're out of town or under the weather, you can join via Teams. But I thought also people who were like snowbirds could do this. And we do have one person who's a snowbird in this group is going to do it. But there's a caveat I found out. In order to do telehealth legally, I have to have a license in that state. I am actually trying to get a license in Florida so that this person can still join our meetings and I can do this legally. Florida, it's free. So if you're in Florida, that'll work great. But if you're going to be snowbirding in Arizona, for example, I can't do that because Arizona, I think getting a license there would cost me $700. So, sorry. So I'm unfortunately going to have to say only snowbirds in Florida can do this. Okay, I'm sure everyone wants to know how I lost weight. You can't read the slide, this print's too small, but basically in September of 2022, I was shocked how I looked in pictures at a family reunion and I weighed 195 pounds and I got COVID at that family reunion and I lost 10 pounds from that. I started using my CPAP again and taking my narcolepsy medicine more consistently, and I lost 6 pounds from doing that. Then I had iron deficiency, had gone through a whole workup, found out I had this huge hiatal hernia, and my mom had the same thing, and I knew that I didn't want to wait to 84 like she did to get it repaired because she said she felt the best she'd felt in her life after she got it done. I'm not waiting to 84 to feel good, so I said, I'm going to do it now. And I was told that I would lose 10 to 15 pounds very fast, but I would gain it right back. And I said, oh no, if I'm going to lose weight, I'm going to keep it off. I'll show you how. So I weighed 179 on the day of surgery. For the first 6 weeks, I was only allowed to walk. So I walked 5 days a week. And one day of the week, I would walk longer and longer. I got up to walking eventually 6 miles on one day of the week. I don't know if that probably wasn't doing that for 6 weeks because I was going up gradually. 3 days before my 6 weeks were up, though, my weight did start to go back up, and I went 3 days early to the gym and weightlifted, and I finished out the week even. So after that, I weightlifted Monday, Wednesday, Friday ever since, and I kept losing, and I was jogging Monday, Tuesday, Wednesday, Thursday, Saturday, usually just 2 to 3 miles, except Saturday up to 6 miles. And Friday at the gym, I was riding a bike 20 minutes for a warm-up. I actually thought I was doing 200 minutes, but I was doing way more than 200 minutes. My math was off because it actually turned out to be 252 minutes. But I did scale back after I did the slide and figured it out because I did think that I was probably losing too fast, and that was probably why my hair was falling out. My stomach capacity was definitely smaller after surgery. I was on a liquid soft diet for 6 weeks, and the first week was hard, but all I did was watch cooking shows, which probably made it even harder. But after that, started finding it strangely satisfying and stuck to it. But then in August, right about the time I was preparing for the first group to start, I started getting weaker despite weightlifting and discovered that my ferritin was very low. I had quit taking iron after the surgery because I thought, well, I shouldn't need it anymore. But I hadn't replaced all the iron that I'd been losing over those years. So I went back on and that got better. And then I had another surgery in October, and it was actually a breast reduction, and so I wasn't allowed to exercise for 6 weeks. So I had to not exercise for 6 weeks. But and for a while, I still kept losing, which was making me pretty nervous, but my weight did finally plateau. And then right about the time they said I was allowed to exercise again, I started to ache all over and was like, what is going on? And I was like, yep, I haven't exercised for 6 weeks, and I forgot that exercise can really reduce pain. And so I started exercising again, and the pain is gone again. So if you have questions, oh, this isn't quite correct. See, this is when I presented it as our first group visit. So at our first group visit, you can bring all your questions about any of this, and or I can recap parts that you don't understand or whatever. But like I said, we're going to have that first group visit on January 10th, and we have to limit it to 20 people because we don't have room for that many people in our facility. And I would like to ask that if you want to participate, but you get sick, unfortunately, you're just gonna have to wait for another session because we don't want anyone coming in that's sick. And but feel free to wear a mask. And so I hope this helps you understand what this is about. And I hope to see at least 16 to 20 people there at the meeting, but that we limit it then to, I can't remember if I limit it to 12 or 16. I think I limit it to 12. So only 12 people can participate. But I have to have a minimum of 6 to do it. So 6 to 12. Okay. Thank you.